soaring high and making difference, where we talk anything about nursing. So let your voice be heard right here. Moments with Professor X.
Good evening, Las Vegas. How's everybody? Oh my God, we're back. It's me again, Sander. Today's actually Sunday, first day of the week, guys. What's your plan for this week? Would you believe it's already July 20, 2025? We're past 20 days, the first 20 days of July, and you'll be surprised a few days from now. I guess less than 15 days, we're done with July, and August will kick in. One more month and we will start celebrating Christmas. So in the Philippines, all my kababayan in the Philippines, don't worry, a few months from now, you will hear what do you call this? Christmas carol. O, diba? Anyway, before I start my lecture, big shout out to Kath Wagpao. Hey Kath, how are you? Where are you now? Are you still working somewhere in Cagayan de Oro City? Anyway, how's everybody? It's what time is it? It's almost 8 p.m. Southern Nevada time, Las Vegas. So that will make Philippines almost 11 a.m. in the Philippines, right? So in the Philippines, ano na ang kakainin natin sa pananghalian? My God, namimiss ko yung mga gulay. Pero kumakain talaga ng gulay, ano? Yung mga sinugba, barbecue, oh my God, I'm starving. Honestly, I haven't prepared something for dinner, for supper. Maybe later. Yeah, Laarni, correct. It's 11 a.m. in the Philippines. Thanks for watching, Laarni Unito. How are you? Manila, how's the recent issue there at Ninoy Aquino International Airport? My God, I'm so proud of you. Okay, for those who are crazy people in Ninoy Aquino International Airport, stop that thing. Okay, please. You're putting the Philippines in limelight again with the worst international airport. Please, guys. So to all my friends who are planning to go to the Philippines and will land in Ninoy Aquino International Airport, please be mindful with your valuable stuff. Hello to Cham Tuazon. Hello, Cham. How are you? How's Mayo Clinic? I miss Mayo Clinic. And how's my friend Ian John Sumagaysay? How is he? Hey, Cham, how are you? I know you're back. You just had your almost 2 months vacation in the Philippines. I know you went to Japan, you went to Australia, you went to the Philippines. Oh my God. When are you coming back here in the UK? Not in the US. When are you coming back here in Vegas? Let me show it to you guys. I don't know if I can pull this thing and show this Facebook Live. Can I do this? Oh yeah. Oh yes, I can. Cham said hello from the state of 10,000 Lakes, Minnesota. Yeah. Yeah, I know. For those of you who just joined this Facebook Live, I used to live there in Minneapolis. I stayed there for almost 2 years and a half. Yeah, hello to Vince. Thanks for watching, Vince. Yeah. I mean, in all honesty, I miss Minneapolis. What are the things that I miss in Minneapolis? Of course, the Mall of America. I miss that. Okay. The bar. I forgot the name of the bar. What do you call that? What is the name of the bar, Cham? What do you call that? The LGBTQ bar. What do you call that? Jessa Ann said, hello, Prof. Hi, Jessa. How are you? Where are you from? Anyway, hello to April Corona. Thanks for watching. Ano to? No more lecture, lahat na lang greetings. Wala lang na. I mean, I have to maximize my time while I'm still here inside my computer room. This coming Tuesday, I'm flying to London, UK this coming Tuesday, and I'll be back on the 31st. Yeah, so most likely I'll be out for 2 weeks, and then you will see me again doing Facebook Live. Most likely second week or first week of August. Okay. April Corona. Good morning, sir, from Cagayan de Oro City. Hello, April. Good morning, CDO, and to all my friends and students in Cagayan de Oro City. You know what? In all honesty, Cagayan de Oro City is special to me. You know, I was able to establish a good network in CDO. And speaking of network, hello and hello to my friend Sir Gift Paguntalan. Jessa Ann said, I'm from Masinloc, Zambales, but currently working in NKTI. What does NKTI stand for? What does NKTI? What is that? Narita? Please let me know. What does NKTI stand for? Is that a facility or what? Zambales. I've never been there. Okay, anyway, let me share my screen and then let's move forward. We'll talk about peptic ulcer disease today, okay? Oh, National Kidney and Transplant Institute. Oh, okay. Oh, speaking of National Kidney Transplant Institute, hello to my friend. I think she's the head nurse now, or the charge nurse, or the head nurse, or the nurse manager. Irene Villa, my long lost friend. She's a dialysis nurse in Davao City. Yeah, I know that we have a lot, or shall I say not we have a lot, we have increasing number of renal failure cases wherever you go. Maybe most likely it's because of the vices and the food we eat. So please take good care of your kidney. Okay? How long you been working there, Jessa Ann? So you're a dialysis nurse? I never, well, you know, I want to work as a dialysis nurse, but maybe not now. Maybe in the near future. Sabi nila okay lang daw, hindi daw masyado ganun ka-stressful compared to working as a bedside nurse in a medical surgical floor. As long as you have a responsible technician, okay yung buhay sa dialysis nurse. Okay, anyway, let me share my screen and we'll talk about peptic ulcer disease. By the way, just a heads up, take note. So we will talk about peptic ulcer disease, and please, if you have friends, if you have relatives, if you have peptic ulcer disease, whatever I'm gonna say in the next few hours, this will not replace whatever management, medical suggestion, medical recommendation, medical management you have, or will not replace whatever conversations you had with your primary care provider. Okay? So stick with your treatment plan, stick with your management plan, or whatever treatment plan you have for your peptic ulcer disease. So whatever I discussed today, this will not replace your treatment. The reason why we do this is to help nurses prepare as they will take their, or as they challenge their qualifying examination. Okay? For those who don't know me, my name is Sander Ray. I've been a nurse for how many years now? I've been a nurse for 23 years. And after I finished my bachelor's program, I took up another program, Bachelor of Science in Respiratory Therapy. And I've been doing NCLEX prep for almost 10 or 13 years now. Not only NCLEX prep, I also do help nurses prepare for their licensure examination. In the Philippines, we call that NLE. NLE stands for Nursing Licensure Examination. I also help nurses take their DHA Prometric HAAD. That's a qualifying examination for nurses in the Middle East. And of course here, the NCLEX RN and NCLEX PN. Okay. So, by the way, if you have any questions, concerns, or anything you want to ask, anything that bugs between your ears, please feel free to drop a message, okay, or personal message to me. Send a PM, and I will try to answer if I know the answer. If not, I will let you know as well. Hello to Ruthie. Ruthie, hello from Switzerland, Sir Sander. Hi. Thanks for watching, Ruthie. You know what? My family, my cousins, were planning to go to Zurich next year. They told me like summer, and but I want to go there like December just to experience, White Christmas in Switzerland. Anyway, let's move forward. So let me share my screen. Let me share my screen and let's go from there. Okay. Oh, nothing Wong. There you are. How are you? Kumusta na nating Wong? Okay, so we'll talk about peptic ulcer disease. Sabi ni Nati Wong said, Nating Wong said, ping pong taanay surgeon. Ping pong, that's other name for the table tennis. We used to play table tennis before I left for the US. And Nating Wong was my student before for the NCLEX RN back in Iloilo City. We have here, new review here. What is this? Tara Juanson, new reviewer here from California. BSN grad December 2025. Hello, Tara Juanson. Where did you finish your nursing? Did you finish your nursing there in California or somewhere else? And you said you're a new viewer, not reviewer, new viewer. So Tara, when are you planning to take your NCLEX? Please let me know. Okay, so peptic ulcer disease. So I will highlight possible questions in your examination, okay? So peptic ulcer, what is this? Let me turn off my bed music. Okay, so what is peptic ulcer disease? Peptic ulcer disease refers to an excavation, okay? An excavation that forms, okay, where that forms, okay, anyway, you have another one. Please, 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 please. What is this? Ruthie said BSN grad 2019 and now working as a home care in Switzerland. Masaya naman. Oh, that's good. You keep safe, okay? I hope to see you once we visit Switzerland next year. And we have Tara Wanson. Yes, expected graduation December 2025. Planning to take the NCLEX within a month after graduating. So that will be most likely first quarter of 2026. Okay. Congratulations in advance, Tara. And please, you will stay, and this is a free NCLEX review, so hope you learn something. Okay, an excavation that forms where in the gastrointestinal tract. Okay, it forms where wall. Okay, on the walls of your gastrointestinal tract. So if you look at the picture of your digestive system, where is that? Here. If you look at the picture of your digestive system, so this is your alimentary canal. Okay, so you call this is your oral cavity. This is your esophagus. I don't know if you can see the cursor moving. So this is your esophagus. Okay, this is your stomach. Okay, this is your small intestine or your small intestine. This is your large intestine or the colon, ascending colon, transverse colon, descending colon, sigmoid colon, the rectum, and the anus. Okay, now When I say peptic ulcer disease, this refers to a sore that develops or an excavation that forms in the linings of your GIT. So an ulcer may develop in the lower esophagus. You call that as your lower esophageal ulcer. Or a sore or an ulcer may also develop in the stomach. You call that as your stomach ulcer, or sometimes we call that as gastric ulcer. Okay. And the third common location of ulcer is an ulcer that develops in the small intestine or small intestine. Okay. And remember, your small intestine is divided into three. Okay. It has three partitions: the DJI, the duodenum, the jejunum, and ileum. It's the duodenum, okay, the common site of your ulcer. Okay. So again, so peptic ulcer disease refers to a sore that develops or an excavation that forms in the linings of your GIT. So you have your lower esophageal ulcer, gastric ulcer, and your duodenal ulcer. Okay. Now there are things I need to stress before we move forward, and that, okay, will be the layers of the gastrointestinal tract. Okay. Now, Professor, why do you need to discuss the layers of the GIT? In order for you to appreciate perforation. And that is one major concern when you talk about ulcer. Okay. Now, if you can still remember in your anatomy and physiology, okay, your gastrointestinal tract has four major layers. Okay. Can you tell me the four major layers of the gastrointestinal tract? Can anybody tell me the four layers? Oh, by the way, hello to Sir Joel Afalia. Hi, sir. How are you? Kumusta na? And hello to Maymar Robin Zuben. Thanks for watching. So, the, this layer here, this is the innermost. You call this a mucosal layer. Okay? Below your mucosa is your submucosa. Okay? Then you have your muscularis. And the outermost layer of your GIT is your serosa. Okay? So these are the four layers of the gastrointestinal tract. So you have your mucus here. Okay? Now, when I say peptic ulcer disease, there is a sore or an excavation. Okay? So can you imagine if there is an excavation that develops in the lining of your GIT? And if not treated, okay, if not treated, what happens with the excavation is that it goes deeper, deeper, deeper until such time that it creates a hole or an opening in your GIT. So if that happens, whatever gastric content you have, whatever contents you have in your GIT, there is a chance that it will leak out. It gets out from the GIT area and it will spread into your peritoneal membrane. Okay. And this is a major complication of your peptic ulcer disease. And you call this as your perforation. Okay. Perforation. And this perforation will eventually result to peritonitis. Okay. Now, please do not forget this concept because I will talk about this again later on as we progress. Okay. And possible question in your examination here: how will you position patient with peritonitis? What are signs and symptoms of patient with peritonitis? What's your priority to patient with peritonitis? Okay. Now, let's move on. Now, so it all stems from peptic ulcer disease that is left untreated. Okay. So there's an excavation that forms in your GIT. Again, peptic ulcer disease has three common types, and the types of the peptic ulcer disease depends where it is situated or located. So an ulcer can develop in the esophagus. You call that as your lower esophageal ulcer. Okay. An ulcer may develop in your stomach. You call that as your gastric ulcer. And an ulcer may develop in your small intestine. You call that your duodenal ulcer. Now, question: among the three types, okay, thanks a lot, Tara. Among the three types of ulcer, take note, what is the most common type of ulcer that you need to understand? Don't forget, it is your, okay, it is your duodenal as the most common type of ulcer. Okay? Your gastric is the second common type of ulcer. Okay? Now, what causes ulcer? Can you identify? What there are two major causes of ulcer. Number one is your H. pylori, Helicobacter pylori. It's a bacteria. Okay. Now, what happens with your H. pylori infection is that it triggers inflammatory response, okay, in the lining of your GIT, and because of chronic inflammatory response, what will happen is that the lining of the GIT will lose its more protective layer. And without this protection, without this coating, okay, without this coating, the hydrochloric acid now will erode your lining of the GIT. Okay. And that's when you will end up getting peptic ulcer disease. Okay. Next, another cause of peptic ulcer disease, drugs. Remember, there are agents, okay? There are agents, medications or drugs that's said to be gastric irritant. Now, please do not forget this in your NCLEX, okay? Now, can you identify common medications that can cause gastric irritation? Okay, I will identify. So you have your aspirin, okay? Aspirin is a gastric irritant. What else? Most antibiotics, okay? Antibiotics are gastric irritants. That is why, please, okay, don't forget this. If a medicine, if an agent is said to be a gastric irritant, it can cause GI upset. Take note, one of the most important nursing education here is to tell your patient to take the medicine with meal or take that with full stomach, okay? Why? Because of GI irritation. What else? Another agent that is said to be gastric irritant, apart from your aspirin, okay, antibiotics, you have your potassium supplement. I am talking about oral potassium supplement. Remember, there's such thing as potassium given as intravenously. Okay, so we're talking about potassium supplement given as an oral preparation. One good example here is your K-Dur, your Kalium Durol. Okay, your K-Dur. What else? Another agent said to be GI irritant are your NSAIDs. Okay, now what are these NSAIDs? NSAIDs are non-steroidal anti-inflammatory drugs. Okay, now, give me an example of non-steroidal anti-inflammatory agents. Okay, so that's the mnemonic NSAIDs. So we'll identify that NSAIDs. So please be reminded, if your patient takes any of this medicine, watch out for GI upset. Okay, N stands for naproxen. Naproxen is an NSAID. S stands for your salicylate. A stands for your Arthrotec. A stands for Arcoxia. I stands for your ibuprofen. I know some of the medicines here are common. D stands for diclofenac. S stands for Sulindac. Take note, these are examples of NSAIDs. Okay, so if your patient takes any of these medicines, remember full stomach or with meal because of GI irritation. So these are identified causes of your peptic ulcer disease. But take note, in your NCLEX, there are risk factors. Okay, what are common risk factors? Okay, common risk factors for peptic ulcer disease. Don't forget this. Okay, type O blood. Okay, a blood type O. And by the way, when you say type O, what blood type? This is a sidestep, as they say, topic. It's different from your peptic ulcer disease. But since I mentioned type O, I just want to say this: type O negative. Type O negative is the safest blood. Don't forget that. If you don't know the blood type of your patient, the safest blood that you give is O negative. Okay? Anyway, let's move forward. Another risk factor for peptic ulcer disease is stress. Okay? Stress. Now, remember, what happens if you're living in a stressful environment or stressful lifestyle? Uh, a stressful lifestyle can cause increased hydrochloric acid production. That is why if you end up having ulcer related to stress, okay, it leads to what we call stress ulcer. Okay? Now, don't forget this. What is another name of stress ulcer? Okay. Another name of stress ulcer is your Curling's ulcer. Okay. So please be reminded, stress ulcer, Curling's ulcer, they're the same. Okay. So one good example of Curling's ulcer, stress ulcer, okay, that may happen to patient is a patient with burn injury. Okay, patient with burns. Why? Remember, a patient with major burn injury because of a TBSA of more than 25%. Okay, remember that's a major burn injury. Uh, if you have a major burn injury, it has a profound effect in the body's metabolism. Okay. So what happens is that a major burn injury will result to massive stress response. Okay. And this massive stress response, okay, one effect there is it increases hydrochloric acid production. Okay. And you will end up having ulcer. Okay. Now, another risk factor for patient with ulcer is patient with brain injury. Brain injury. Okay. Now, brain injury, common issue here is increased intracranial pressure. Why? By the way, what is the normal ICP? The normal intracranial pressure is less than 15. Okay. The normal intracranial pressure is less than 15 millimeters mercury. Now, look, what happens if you have increased ICP? For example, patient had a hemorrhagic stroke, or patient with some arachnoid bleeding, or patient had brain trauma, had an accident that causes brain injury, and eventually there will be increased ICP. Now, the effect is that an increase in the intracranial pressure will result to increased hydrochloric acid production. And again, this will result to ulcer. Now, listen carefully. What do you call that ulcer related to brain injury? What do you call that ulcer related to brain injury? You call the type of ulcer as your Cushing's, okay, or Cushing's ulcer. Now, please do not confuse yourself with Cushing's syndrome, okay? Cushing's ulcer, and there's another one, Cushing's triad, okay? They may have the same first name, Cushing, but they're not the same issues, okay? So allow me to discuss those two additional concepts. So anyway, what is Cushing's ulcer? Cushing's ulcer or Cushing's ulcer is a type of ulcer related to patient with brain injury. That is why don't be surprised if you have a patient in the ICU who had a stroke, patient who is bedridden or bedbound, patient with spinal cord injury, or any injury attributed, okay, that can cause increased intracranial pressure. Most often than not, the doctor will prescribe anti-ulcer agent. Why would the doctor prescribe anti-ulcer agent? The reason why doctors prescribe anti-ulcer agent as prophylaxis for Cushing's or Cushing's ulcer. Okay? Don't forget that. Anyway, now let's move forward. Now, what about Cushing or Cushing syndrome? What is this? All live MS lecture, Sir John, updated, please. Thank you. What do you mean? Let me share this. Hold on. I can't see my monitor. Hey, where are you? I can't see the screen. There. Bernardo, what do you mean by this? Hey, Bernardo Valle, what do you mean by that? Okay, anyway, Cushing syndrome and Cushing or Cushing's triad. Remember, they have the same first name, Cushing, okay, but they're not the same, okay. Remember, they have different last name. The one is ulcer, the other one is syndrome, the other one is triad. Okay, now what is this? What is Cushing syndrome or Cushing syndrome? Cushing syndrome Now, what is Cushing syndrome? Cushing syndrome or Cushing syndrome is a form of an endocrine problem, an endocrine disorder. As an endocrine problem, you expect that there will be imbalances with the hormones. Okay. So, in your Cushing or Cushing syndrome, expect that a patient here will have an elevated cortisol, okay, elevated aldosterone, okay, and an elevated adrenal androgen. Okay. By the way, another name of cortisol is your glucocorticoid. Another name of aldosterone is mineralocorticoid. Okay. So that is why a patient with Cushing syndrome, because of an elevated adrenal hormones, your patient here will have increased SS. Now, what are these increased SS? High in sugar, okay, high in salt, and increase in patient's sexual activity, increased libido because of increase in the androgen. Okay, so you call that problem as your Cushing or Cushing syndrome. Now, if you incorporate this in your exam, possible question here: diet of your patient. Now, remember, a patient with Cushing syndrome has high sugar. Patient is hyperglycemic. Patient will have hypernatremia and hypokalemia. So, what would be the diet of a patient with Cushing syndrome? The answer in your examination must be low carb, low sodium, high potassium, limit water intake. Why? Because a patient with Cushing syndrome, too much sodium can cause fluid volume excess. So there will be dietary modification. Okay. Anyway, most likely I will discuss endocrine once I'm back after my short vacation. Okay. So that's your Cushing syndrome. Now, what about Cushing or Cushing's triad? Okay, your Cushing or Cushing's triad is actually a manifestation of patient with increased intracranial pressure. Okay, so your Cushing or Cushing triad is a manifestation of patient with increased ICP, usually on the late stage of patient with increased intracranial pressure. Now you call it triad because in Cushing or Cushing's triad, it has three presentations. Okay, so what are the three presentations of patient with Cushing's triad? So patient with increased ICP. Number one, there will be an increase in your systolic blood pressure. There will be a decrease in your diastolic blood pressure, and there will be a decrease in the patient's heart rate. Okay. Now, take note, what will be the effect? What is the implication when the systolic pressure increases and the diastolic pressure drops? When this happens, okay, when this happens, expect that there will be widening of the pulse pressure. Okay. Question: what is the normal pulse pressure? The normal pulse pressure ranges from 40 to 60 millimeters mercury. This is the normal pulse pressure. And by the way, if you don't know, how do you get pulse pressure? To get the pulse pressure, all you have to do is to subtract, get the difference, get the difference between your systolic and the diastolic. Let me give an example. Now, let's say just an example, let's say the BP of your patient is 120 over 80 millimeters mercury, and the heart rate of your patient, let's say, is 81 beats per minute. Now, question: are these within normal limits or within normal parameters? Yes. 120 over 80 blood pressure is the ideal. Okay, very normal. Now, with these numbers, what is the pulse pressure? Again, you subtract systolic from diastolic, and that will be 40. Remember, 120 less than 80 will give you a difference of 40. So it's within the range. Okay, so a patient with increased intracranial pressure, let's say the 120 of the patient's systolic bumps to 160. Okay. And then let's say that the diastolic pressure of your patient drops to, let's say, 50. Okay. This is the blood pressure of your patient, 160 over 50. And let's say the heart rate of the patient went down from 81, it went down to 48 beats per minute. So this is what we call Cushing's triad or Cushing's triad, a manifestation of patient late stage of increased intracranial pressure. Remember, 160 over 50, the pulse pressure is greater than 60. Look at the difference, right? It's very high. And the heart rate of the patient drops. So this you call this a short Cushing's triad. Okay? Anyway, let's move forward. Now, so patient with peptic ulcer disease, again, a peptic ulcer disease may develop may occur in the lower esophagus. Okay? By the way, this is your stomach. Can you identify the parts of your stomach? This is the lower esophageal area. Okay, the sphincter on this side. I don't know if you can see the cursor moving. You call the sphincter here as your cardiac sphincter. And this part here is the fundus of the stomach. Don't forget, it is the fundus of the stomach that dilates, not dilates. I don't think dilates is the appropriate term. That distends. I think that's the most appropriate term. It is the fundus that distends primarily to accommodate the food that enters your stomach. It is in the fundus that you will have a lot of nerve endings that will send an impulse to your brain that your stomach is already full. Okay? It tells you, hey, you have to stop eating now because your stomach is full. Okay? Now, this part here is the body of the stomach, and this is the antrum of the stomach. Okay, and the lower part is your pyloric sphincter, and that is connected to your small intestine. Okay, now highlight in your exam antrum. Okay, take note. It is the antrum. Okay, it is the antrum of the stomach where you can find a lot of parietal cells. Okay, now what is that cell for? Is that for decoration purposes? No. Parietal cells are cells responsible in producing hydrochloric acid and produce it. Also, it will help produce, not help, it will produce intrinsic factor. Okay, let me write it down. Okay, let me write it down. So let's say if this is your stomach. Okay, please bear with my drawing. Okay, the antrum is here. Okay, it is in the antrum where you can find a lot of parietal cells. Your parietal cells are cells responsible in producing hydrochloric acid. And by the way, hydrochloric acid is a legit acid. It is corrosive. Okay. Now, this acid is essential for digestion, digestion breaking down into its smaller form. Okay. And what else? Your parietal cells are also cells responsible in producing intrinsic factor. Intrinsic factor. Now, what is this intrinsic factor for? Your intrinsic factor is important because, okay, your intrinsic factor is important for the absorption of your vitamin B12. Okay, B12. Now, what is another name for vitamin B12? You also call that as your cyanocobalamin or your cobalamin. Professor, what is the significance of your vitamin B12? Your vitamin B12 is important because your vitamin B12 is essential for the DNA and the RNA synthesis, okay, of the red blood cells. That is why, in short, to make it simple, your vitamin B12 plays a vital role for RBC production. That is why if you don't have vitamin B12, it affects blood cell formation. I'm talking about RBC, and this will result to a condition called anemia. Now, what do you call that anemia related to B12 deficiency? You call that type of anemia as your pernicious anemia. Okay? Now, take note. What part of the stomach has a lot of parietal cells? I said antrum. Not only intrinsic factor, okay, is a substance produced by the parietal cell, it will also produce hydrochloric acid. Now remember, our topic is peptic ulcer disease. Peptic ulcer disease is an excavation, correct? That is why one management of your peptic ulcer disease is to decrease hydrochloric acid production. So how do we do that? In order to decrease hydrochloric acid is to decrease parietal cell count. How will you decrease parietal cell? By removing the antrum. Okay? Now, what do you call that surgery? Removal of the antrum. You call that as your antrectomy. Antrectomy is removal of the antrum. So take note, highlight in your exam. Post-antrectomy. After antrectomy, expect that when you remove the antrum, the parietal cell number decreases, leading to decreased hydrochloric acid, which is beneficial to patients with peptic ulcer disease. But along the way, it will also decrease intrinsic factor production, leading to pernicious anemia. That is why, what will you watch out for post-antrectomy? Watch out for pernicious anemia. Not only pernicious anemia, since it's a gastric surgery, you have to watch out for dumping syndrome. Okay? Watch out for dumping syndrome. We will discuss that later. Okay? I'm just giving you the overview. Okay? Now let's move forward. I also mentioned that ulcer also can also be seen in your small intestine. That one. Now let's proceed to. Oh, by the way, this is your ulcer in the lower esophagus, lower esophageal ulcer. That one through your endoscopic view. So they did some endoscopy procedure. This is your ulcer in the gastric area. Okay, that's brought about by NSAIDs, your non-steroidal anti-inflammatory. Okay, and this is your ulcer in your duodenum area, duodenal with perforation. Okay, so perforation in the duodenal ulcer. Okay, so again, remember there are three common types of ulcer depending on its location. Now, let's proceed. Let's talk about signs and symptoms of your patient. Now, tell me, what are signs and symptoms of patient with peptic ulcer disease? Signs and symptoms of peptic ulcer disease. Number one, patient with peptic ulcer disease, they have nausea and vomiting. Okay. Number two, patient will have anorexia. Okay. Loss of appetite resulting to weight loss. Number four, because of an ulceration, expect that the patient complains abdominal pain. Now, do not forget this in your exam. You put some asterisk. Highlight in your exam. Tell me, where is the location of your abdominal pain for peptic ulcer disease? It's usually in the mid epigastric area. Okay? Mid epigastric area. Now, highlight in your exam. When you talk about abdominal pain for peptic ulcer disease, how will you describe the pain of patient with PUD? That depends. Okay, that depends on the peptic ulcer disease. If the type of peptic ulcer disease is gastric ulcer, okay, if the type of ulcer is gastric ulcer, abdominal pain here is characterized as pain aggravated by eating and usually relieved by vomiting. Okay. But if the type of ulcer is duodenal ulcer, how will you describe the abdominal pain of your patient? The abdominal pain of your patient is a pain relieved by eating. So again, so don't forget this. When you eat, okay. Oh, sorry. I dropped my stylus. Okay. So please don't forget this. When you eat, so let's say I eat. So when I eat, the pain worsens. Okay. When I eat, the pain intensifies. Most likely that's your gastric ulcer. Okay. And if I throw up, okay, if I throw up, the pain disappears. Most likely that's your gastric ulcer. Remember, in your gastric ulcer, the sore, the wound, the ulceration is in the gastric area, correct? Okay. So what happens if you eat is that when the food enters your stomach, that food now irritates the wound, it irritates the ulceration, it irritates the sore. That is why when you eat, the pain intensifies. When you eat, the pain worsens. But when you throw up, okay, the irritation there is being eliminated because you throw up, then the irritation disappears. So that is why when you throw up, the pain disappears. Pain is relieved by vomiting. Okay. But when you eat, the pain disappears, then most likely that is your duodenal ulcer. Okay, just a recap. Okay, so that you won't get confused. When you eat, the pain intensifies, that's gastric ulcer. When you throw up, the pain disappears. Again, that's gastric ulcer. But when you eat, the pain disappears, most likely that's your duodenal ulcer. Okay? I hope that's clear. Now let's move forward. Now, what else? Number five. This one. Number 5. Patient with peptic ulcer disease may also develop bleeding. Okay, why? Remember, there is an ulcer formation. Okay, now highlight in your exam. Because of bleeding, there's a chance that when the patient throws up, patient will have hematemesis. Okay, hematemesis. When you hematemesis, when you throw up, there is blood. Okay, now how would you describe? How will you describe the barf of your patient? Okay, so you will have here a coffee ground. Okay, a coffee ground emesis. And because of bleeding, sometimes when you poop, you will see blood in the stool. But remember, the blood of the patient here is not fresh blood in the stool. Okay, it's your melena. So you will have a black, tarry stool. Okay, just a highlight. If the poop is black tarry melena or black tarry stool, most likely the bleeding is in the upper GI. But if the poop is fresh blood, you call that your hematochisha, most likely the bleeding is in the lower GI. Okay, don't forget that. Next. Now, that is why, because of bleeding, number 6, additional manifestation, patient may have anemia. Your anemia here is related to bleeding, and your anemia here is related to anorexia. Okay? And number 7, don't forget perforation. Okay? As a complication of your peptic ulcer disease, which will eventually progress to a condition called peritonitis. Okay? Highlight in your exam. Now, a patient with peritonitis, tell me, what are signs and symptoms of a patient with peritonitis? Patient will have severe abdominal pain. Patient with peritonitis will have fever. Patient with peritonitis may develop signs and symptoms of shock. Patient with A, B, C, D, E. Patient with peritonitis will have board-like abdomen. Board-like abdomen. Now, take note, sometimes they don't use this board-like abdomen. They will use another term. You call this as abdominal rigidity. Abdominal rigidity. Okay? So these are common presentations of your patient. Okay? Now, if you suspect peritonitis, please don't forget this is a medical emergency. You tell the doctor ASAP. Okay? With no delay. Now, if doctors or if you suspect peptic ulcer disease, can you identify possible diagnostic test? What are common diagnostic tests for patient with peptic ulcer disease? Number 1 is your endoscopy. Now, highlight in your exam, what is endoscopy? An endoscopy is an invasive procedure wherein an endoscopy is an invasive procedure wherein the doctor inserts a fiber optic tube, into the patient's mouth, threaded it until such time it reaches your esophagus, goes to your stomach, and you can visualize a small part of your small intestine. Now, by the way, your endoscopy is the short name. The complete name is esophagogastroduodenoscopy. Oh God, that's mouthful. I like this because it explains the entire procedure. What is that? Esophago, esophago, gastro. Hold on. Hey, oh my God. Okay, I'll just write it here. You called it your esophago, gastro, duodenoscopy. So there is, when you say scopy, there is visualization. Visualization of the esophagus, the gastric area in the duodenum. Okay, esophagogastroduodenoscopy. Okay, that's the mouthful. That's a complete name. The nickname is endoscopy. Now highlight in your exam. Of course, endoscopy requires doctor's order because it's invasive. Again, your responsibility as a nurse here is to witness signing of the consent. The doctor should obtain the consent. Okay. Preparation, take note, place the patient on NPO. Okay. NPO prior to the test, usually about 8 hours before the procedure. Now, to prevent aspiration, okay? Make sure that during the procedure, the stomach is well prepped, okay, for the procedure. So you have your endoscopy. Next, post procedure, it's normal for the patient to complain some sore throat. That's okay. When the patient cough out, it's normal to have some blood streak in the phlegm, in the mucus of the patient. That's also normal. But in the event that there's massive bleeding, that's already an abnormality. You tell the doctor about that. Next, post endoscopy, you have to maintain the patient in NPO until gag reflex is present. Don't forget that. Okay, those are things you need to remember. Next, number two, what else? Your urea test breath test. This will check presence of H. pylori. Oh, by the way, in your endoscopy, they can also check presence of H. pylori. How do they do that? So when they insert the fiber optic tube, they can get a tissue specimen and check for presence of H. pylori. Okay, next. Another test. You have your upper GI series. Okay. By the way, another name for upper GI series is your barium swallow. Barium swallow. Okay, barium swallow. If it's barium enema, that's your lower GI series. Okay, so your barium swallow, sometimes in the barium swallow, it will reflect the area with excavation or ulceration. Okay, your barium swallow is also done if you want to check gastric emptying time. So there are several reasons why we do barium swallow. Okay, remember one common issue with barium swallow is constipation. So don't forget that. Next, number four, another test is sure, of course, your blood exam. You check presence of anemia, your CBC. Number five, oh here, guayak test. I don't know if you're familiar with this. Guayak. How do you spell that? Hold on. It's really hard. If it's been a while, no, it's been a while. I haven't written this word, and you tend to forget their correct spelling. Hold on. Guayak. Oh, man. I don't know. Guiac. Guayak test. Please check the spelling, okay? I'm so sorry. I forgot the spelling of guayak test, but I know it starts with letter G. Another name for guayak test is your fecal occult blood test, okay? Or your guayak test, okay? So your fecal occult blood test or guayak test is a test that will check presence of blood in the stool, okay? It check presence of blood in the stool. Now highlight in your exam. If your patient is scheduled for guayak test, okay, take note. If your patient is scheduled for guayak test, no red meat, no aspirin, no NSAIDs, okay, when at least 3 days before the test. Why? Because it will give you a false positive result. Okay, don't forget that. Now, next, treatment. How do we treat patient with peptic ulcer disease? Okay, of course, there must be stress reduction. Rest is also important. What else? Part of the treatment here is smoking cessation. Remember, smoking is another risk factor. Smoking can is another risk factor for peptic ulcer disease. What else? Stress reduction, rest, smoking cessation, and of course, don't forget you have your anti-peptic ulcer drug. Okay, highlight. Sir, can you give us a mnemonic? A mnemonic for anti-peptic ulcer agent? Sure. So I have here always help people see clearly. Okay? Always help people see clearly. A stands for antacid. H stands for your H2 blockers. P stands for your proton. This is your PPI, proton pump inhibitors. Inhibitors. S stands for your sucralfate or your caraphate. And C stands for your cytotec. This is your misoprostol. Now let's begin with your antacid. Okay. Your antacid, of course, it neutralizes acidity. Okay. Highlight in your exam. Give me an example of antacid. Example of antacid is your milk of magnesia. Okay. Another example of antacid is your amphogel. Now, what is the generic name of milk of magnesia? What is the generic name of milk of magnesia? The generic name is magnesium hydroxide. The generic name of amphogel is aluminum hydroxide. Okay? And another example of antacid is your Maalox. What is the generic name of Maalox? Generic name of Maalox, you just combine these two. So you have your milk of magnesia, that's your magnesium hydroxide, and aluminum hydroxide. So in short, if you combine amphogel and milk of magnesia, that's your Maalox. Now highlight in your exam. Take note. I don't know if you can still see this. Now remember that milk of magnesia contains magnesium. Okay? Now if your patient is having renal failure, okay? Patient having renal failure, a patient with renal failure has hypermagnesemia. Okay, why? Because if you have renal failure, you have renal insufficiency, renal problem, your kidneys cannot eliminate waste products. Okay, your kidneys cannot eliminate excess electrolytes, excess water. So chances are, patient with renal failure will end up having hyperkalemia, hypermagnesemia. Okay, hyperphosphatemia, hypocalcemia. Okay, focus with your magnesium imbalance, which is very high, hypermagnesemia. Now, what will happen? Now, because of too much magnesium to patient with renal failure, never give milk of magnesia as antacid because milk of magnesia contains magnesium hydroxide. The moment you give milk of magnesia, then the more it causes hypermagnesemia or magnesium toxicity. Same thing, never give Maalox. Why Maalox is not good to patient with renal failure? Because again, Maalox contains magnesium. That is why between Maalox and Amphogel, the best antacid for patient with renal failure between Maalox and Amphogel is your Amphogel. Okay? Because it does not contain magnesium. Don't forget this in your exam. Okay? Next, what about H2 blockers? Your H2 blockers, your histamine 2 blockers. Okay. Now, an example of your H2 blocker is your ranitidine. Ranitidine. Or you call this as your Zantac. Okay. What else? Cimetidine. Okay. Or you call this as your Tagamet. I hope these medicines are familiar to you guys. And then you also have famotidine. You know, the brand name of famotidine, this is your Pepsid. Okay. Next is your PPI. By the way, your PPI is expensive than your H2 blocker. Your proton pump inhibitors. Okay. What does it do? It is a drug that decreases hydrochloric acid. Okay. Your PPI. Example of your PPI is your omeprazole. Omeprazole. Okay. Brand name of omeprazole is your hold on. Omeprazole is Prilosec. Prilosec. Another is your lansoprazole. 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 This is your Prevacid. Okay. Then another one is your another is your pantoprazole. Pantoprazole. Okay, brand name here, Protonix. I always give this medicine in the morning. Protonix. I always flush this with 10 cc of normal saline. Okay, your sucralfate, on the other hand, your sucralfate, this is a form of a coater. Okay, so what does it do? It covers the ulcerated area. It coats the ulcerated area. Okay, that's your sucralfate, or you call this as your carafate. Cytotec, this is your misoprostol. Okay, now, your cytotec is a form of a prostaglandin E1, okay, analog. So what does it do? It protects the lining of the it protects the lining of your GIT. It will also decrease hydrochloric acid production. Okay. Now, by the way, if you're aware, in your OB nursing, we give cytotec because it will facilitate delivery of the baby. If you give this prematurely, it may have an abortive fascia effect. Okay, it can be used as a form of abortion drug. Okay, now, so these are common anti-ulcer agents. Now, highlight in your exam, when will you give this medicine? Okay, when will you give this medicine? So remember, AHPSC. What is this? What does AHPSC stand for? What's the mnemonic I gave you? Always help people see clearly. So if you know that, please don't forget after with, before with. What? After with, before with. So don't forget this. After with, before with. So if you'll be asked in your exam, when is the best time to give antacid? Your answer, after meal. When will you give H2 blocker? Answer, with meal. When will you give PPI? Before meal. When will you give sucralfate? Before meal. When will you give cytotec? With meal. So don't forget, after with, before with. Okay? Next. Now, apart from your pharmacologic treatment, other treatment includes, of course, you have your surgery or your procedures. Okay. Number one, you have your vagotomy. Vagotomy. Remember the vagus nerve. Okay. The vagus nerve will affect hydrochloric acid production. So vagotomy is a procedure wherein the doctor cuts the connection of the vagus nerve in order to decrease hydrochloric acid production. I mentioned number two a while ago, and that is your antrectomy. Okay, that's removal of the antrum. Remember, the doctor removes the antrum because majority of the parietal cells can be found there. So post antrectomy, expect that the parietal cell count will decrease, leading to a decrease in your hydrochloric acid production and a decrease in your intrinsic factor production, which will eventually affect vitamin B12 absorption, leading to pernicious anemia. By the way, pernicious anemia, what is the confirmatory test for pernicious anemia, if you know? The correct answer is Schilling's test. Anyway, number three. Another procedure is Billroth 1. Billroth 1. Another procedure is Billroth 2. So they can do this. Billroth 1, Billroth 2. Now, what is another name for Billroth 1? So remember, in Billroth 1, what doctors do is they resect part of the stomach, they remove part of the stomach, and then they anastomose that with your duodenum. So there is resection of the stomach and anastomosis with duodenum. So another name for Billroth 1 is gastroduodenostomy. What? Gastroduodenostomy. So there is gastric resection and anastomosis with the duodenum. So gastroduodenostomy is Billroth 1. For Billroth 2, still there is gastric resection. There's removal of your stomach, not the entire stomach, just part of it, resection, part of it. And what's being anastomosed in Billroth 2 is not the duodenum, but the jejunum. That is why another name for builder 2 is gastrojejunostomy. Gastrojejunostomy. Okay? Gastrojejunostomy. Now, take note. So, I already mentioned this highlight in your exam. Now, post surgery, okay, post surgery, you need to watch out for a condition called dumping dumping syndrome. Okay, dumping syndrome. Now, what is dumping syndrome? Okay, we're almost done. Your dumping syndrome is a condition wherein there is rapid passing of food into your small intestine without proper mixing and digestion. What do you mean? What do you mean? Remember, this is your stomach, correct? Okay. This is the fundus. This is the body. Part here is your antrum. And there's a sphincter here. You call the sphincter as your cardiac sphincter. And another sphincter here, the inferior part. You call that as your pyloric sphincter. Now, remember when the food enters your stomach, and by the way, we don't call that food, we call that bolus. Remember, when you chew the food, when you let not when you introduce the food into your mouth, that food mixes with your saliva. Okay? When food mixes with saliva, you call that as your bolus. Okay? So the bolus now is swallowed. When swallowed, goes to your esophagus and then enters your stomach. That bolus mixes with the gastric juice. Okay, when bolus mixes with gastric juice, okay, you call that as your chyme. So is chyme acidic? It is because it has gastric juice in it. And gastric juice contains hydrochloric acid. Okay, so your chyme is acidic. Anyway, so the bolus enters your stomach. Now, what happens in your dumping syndrome is that, remember, ideally, the bolus should stay for quite a while, not really long period of time, for a few minutes to hours in your stomach for digestion. And then gradually, that will be expelled out from the stomach. It enters your small intestine. Remember, the small intestine has three divisions: the DJI, duodenum, jejunum, ileum. That's the normal physiology, right? In normal anatomy. So gradually, they will be released out, regulated by this pyloric sphincter. Now, what is dumping syndrome? Your dumping syndrome means that, okay, there is rapid passing of food, okay, from the stomach to your small intestine, okay, usually to your jejunum, to your ileum, without proper mixing and or digestion. You call that as your dumping syndrome, okay? So what about if it's the other way around? So this one, the food goes, okay, food goes down rapidly without proper mixing and digestion. What about if the food goes back? It goes up. If the food goes up, you don't call that dumping, you call that as your GERD. You know GERD? Gastroesophageal reflux. There's reflux or regurgitation. Okay? We will discuss that in a bit. Now let's focus with your dumping syndrome. Now, patient with dumping syndrome, tell me, what are signs and symptoms of your patient? What are signs and symptoms of patient with dumping syndrome? Dumping syndrome. Okay? Patient with dumping syndrome develops anorexia. Patient with dumping syndrome will have nausea and vomiting. Patient with dumping syndrome develops diarrhea. You know, diarrhea. Okay. Patient with dumping syndrome develops abdominal cramps. Number 5, patient develops tachycardia. Number 6, diaphoresis. These are common manifestations of your patient. Okay. So that is why, to prevent dumping syndrome, there are things you need to remember. Okay. Now let's begin. To prevent dumping syndrome, what must be the diet of your patient? Okay. Diet of the patient must be high protein, okay, and high carbohydrate. But avoid simple sugar, simple sugar. Okay, and take note. Uh, Eat slowly. Do not eat voraciously like this is your last meal. Okay, eat slowly. And what else? Small, frequent meals. Okay, and what will you avoid for dumping syndrome? Okay, to avoid dumping syndrome, okay, to prevent dumping syndrome, you need to avoid alcohol, avoid cold or hot foods or beverages, avoid, I mentioned large meals, avoid dairy products. What else? Avoid water with meals. That is why the question in your exam, when is the best time for the patient to drink water to prevent dumping syndrome? Okay. Not water with meal, but water between meals. Okay. Not with meals. It's not that a spoon of food and then you drink water. Remember, if you drink water with meals, the more it facilitates dumping syndrome. Okay. Please don't forget that. And how will you position your patient to prevent dumping syndrome? What is the best position? The best position here is low Fowlers. Or if you cannot see low Fowlers, the best position is your left side lying. Why left side lying position? Remember, this is your stomach. Okay. This is the right side. This is your left side. So if you assume right side lying position, then the more it facilitates dumping of food, rapid passing of food. So you position the patient on the other side. So that will be left side lying position. Okay. Normie Musa said, watcher from Puna, Piagapo, Lanao del Norte. Thanks for watching. Okay. So that is your dumping syndrome. Now, what about GERD? You know, GERD, gastroesophageal reflux. I said in GERD, there's reflux or regurgitation. So things to remember here. What will be the diet of your patient to prevent GERD? The diet must be high in protein, but low in fat. And take note, to avoid GERD, avoid the following foods. Avoid alcohol, avoid citrus juices. Okay, avoid spicy foods. Okay, and please don't forget, avoid carbonated beverages. Okay. Anyway, big shout out to all those students right now. So here, Normie said, watcher from Puna, Piagapo, Lano del Norte. Thanks for watching. I'll give you a round of applause. Then we also have Juliet Malage Hamada watching from Hawaii. Sir John. It's okay. Thanks for watching. Hawaii. I've never been there. I'm gonna go to Hawaii. But they told me that Hawaii is really pricey. Is it true? So I need to save first so that I can go visit there. So please, 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 if I'll be in Hawaii, let me know. I will let you know so that we can meet. Okay. Anyway, so that's your GERD. Now I'll have. I think I have a picture here for GERD. Let me see. That's your peptic ulcer. What is this? Oh, here. This is your ulcer. Look. So if you look, there's an ulcer in the stomach, ulcer in the duodenum. Okay. Can you still remember the layers of the gastrointestinal tract? Remember the 4 layers of the GIT, if you can still recall? Okay. I'll try to pause the video. There. Let me pause. Hey. Hey, 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 hey. No. Let's move on this side. Okay, here. I don't know if you can see the cursor moving. So you call this layer here as your mucosa layer. This is the mucosa layer. This is your submucosa layer. This is your muscularis layer. And then the outermost layer is your serosa. Can you imagine if the excavation there, the ulceration is really deep, eventually it makes a hole. So what will happen is that this will result to perforation. I mentioned that. So you call this as your peptic ulcer disease. Okay? There. Okay. Tara once asked, Sir, how often do you do your lives? Depends on my mood, but usually I do that every Saturday, but it depends on my mood. But I usually do once or twice a week. Okay, I think that's all. If you have any questions about peptic ulcer disease, please let me know. You have any clarifications? If none, guys, thank you so much for your time. Okay, who do we have here? Let me see. Thanks for watching, Juliet Malake Hamada. Thanks for watching. Thank you, Sir Ricafort. Oh my God. Complete name. Complete talagang apelyido, ano? Oh, by the way, for the information, I already changed my name from John Gil Ricafort to Sander Ray. But you can still call me a Sir Ricafort or Sir John. That's fine. Okay, anyway, that's all, everybody. Thank you so much for your time. God bless. I hope to see you again. I think this is my last Facebook Live for this week. The next Facebook Live will be first week of August or second week of August. Okay? God bless everybody. Keep safe.